Hello, my name is Scott Malone. I'm Boston Bureau Chief for Reuters News, and I'll be your moderator today. Our panelists, starting from my immediate right, are Steve Beshear, former governor of Kentucky, Kathleen Sebelius, the 21st United States Secretary for Health and Human Services and former governor of Kansas, Jim Douglas, former governor of Vermont, Jack Markell, former governor of Delaware, and joining us remotely we have Ted Strickland, former governor of Ohio. This event is being presented jointly with Reuters, and it is part of the On the Low series on current science controversies. We're streaming live on the websites of the Forum and Reuters, and we're also streaming on Facebook. You can also participate in the live chat that's happening on the Forum site right now. More than 115 Americans die from opioid overdoses every day. It's a crisis that shows little sign of abating. Emergency rooms, tracked by the CDC, reported a 30% jump in overdoses in just 1 year. This isn't the first time that the Forum has addressed this public health crisis. Last year, Steve and Ted joined another panel of governors to discuss the magnitude of the problem on both the state and national level. Despite the fact that so many of us have been touched by this issue, public surveys show that Americans are divided on whether addiction to prescription painkillers can be treated effectively. This creates a bit of a mismatch between public perception and policy making. Today, we'll take a look at some of the measures that have been working or not working on the state level. And we'll also look at discrepancies between state and federal funding and messaging around the opioid emergency. Steve, I understand that many Americans don't understand how or whether treatment can work. Tell us a little bit about this gap in understanding and why it's important.
Well, I think everybody in this room, and I think most Americans do understand that we've got probably the biggest healthcare crisis in many a year with this opioid crisis that is just devouring our country right now. And I think they understand some of the stuff that we as governors have done and are doing in our states, you know, with getting naloxone out in the hands of first responders to save lives, and the prescription monitoring systems that are used to cut down on doctor shopping and closing up the pill mills. I think all of that is at least generally understood, but the one big area that I think people don't have much understanding of is the treatment area. And I think Dr. Blendon here with his group did a poll that indicated that only about half of Americans feel that there is an effective long-term treatment for addiction. And the rest of them just really don't know. And I'll tell you why I think they feel like that is because we haven't really been on a national scale very successful in treatment. They don't look out and see, look at all these people who've recovered and are back into our workforce and are being productive citizens. And that's because we haven't made the kind of commitment. This is the one area. We can do more in every area of this problem, but this is the one area where I think we've fallen woefully short, and that is this treatment area. Give you a kind of a comparison. You know, when HIV/AIDS hit in this country, we ended up declaring that a national epidemic, and we came up with a national response. We spent the money necessary, and we got control of that. We haven't really done the same thing so far with opioids. When you compare that this last Congress is putting, I think, $6 billion in, that's a huge amount of money. But when you compare it with the $32 billion that's being spent in the same time period on HIV/AIDS, it just shows you that I don't think we're there yet on the commitment, and we've got to ramp it up.
Okay. Kathleen, states don't operate in a vacuum. Talk to us a little bit about the role of the federal government here and what solutions should belong to the states and what can only be done with federal resources, and how should we balance those competing abilities?
Well, I agree with what Steve has said in terms of treatment being one of the areas that's the least understood and least well funded. And this has to be a partnership. I mean, this problem has been growing for 20 years. It's not going to be solved in 2 months or by one bill. So I think a couple of things from the federal level are absolutely essential. Clarity of policy, which we do not have right now. Do we believe that treatment is an essential part? Then ideally we would have an administration that would cease trying to take payment for treatment away from millions of people who desperately need it. Stop trying to roll back Medicaid expansion. Stop undermining the framework of the Affordable Care Act, which said that every insurance policy sold to individuals had to have substance abuse and addiction treatment as a part of those insurance policies. That didn't exist before 2014. So we have this massive, on one hand, expansion of access to treatment, and that's being fought. The Justice Department continues to believe this is a criminal justice issue, lock them up, which has been a proven failure and cost a lot of money. And, you know, instead of a public health crisis, which I think not most governors would adopt, as well as a lot of American public. So that's clear. The other thing is Congress, I think, has an obligation as a partner to have sustained and substantial funding. Steve already referred to the fact, I think you're actually a little high. My last numbers say about $4.5 billion real dollars is on the table right now. There's more being talked about, but $4.5 billion. Experts say we need 60 over 10 years. States cannot build an infrastructure for a workforce that frankly doesn't exist. We need healthcare providers, we need trainees, we need people who deal with addiction, and they can't build treatment beds and other facilities with short-term dollars. So governors don't have tons of extra money in their budget, if any, and I think unless the federal government follows up on their health crisis declaration with really substantial and sustained dollars, this will not be solved. I would say the third thing is just a recognition that we have a crisis that people are able to flip types of drugs. So the move from opioid to a cheaper version, and one would say stronger version called heroin, and then on to fentanyl, is, I think, an illustration that treatment is the only way to stop this. This isn't an opioid issue, it is an addiction issue. And unless we deal with it as an addiction issue, it continues to go on.
Right. Ted, I know that your state, Ohio, has been particularly hard hit by opioid addiction. Can you give us a little bit of the view of the problem as you see it from there?
Well, greetings from the heartland, and I can report to you that this crisis is continuing to grow in Ohio. In 1 week, we had 18 people die just in Columbus, Ohio alone. Ohio has lost, in the last 12 months, well over 5,000 lives to this scourge. And I would just like to say that I agree with what Steve and Kathleen have said. We need resources in order to fight this scourge. But I believe we also need a public awareness campaign. Everybody talks about this being a crisis, and it is. But I think as a country, we have not yet recognized how serious it is. We are losing more Americans to this scourge 1 year than we lost during the entire Vietnam War. And recent polling by the Harvard School and Dr. Blinden indicated that that Americans do not consider increasing national action to reduce these deaths a major priority. Only 24% of Americans listed it as a major priority. So I think there needs to be a public a public information campaign carried out. I think we need to recognize, as Kathleen has said, that this is not just an opioid problem. We are seeing here in Ohio, and I believe across the country, increased deaths related to methamphetamines mixed with cocaine, mixed with fentanyl. And so what I would suggest is that we need to understand that we cannot solve this problem without a plan. We need resources, and we need to recognize that there is no quick fix. People who enter into treatment need more than just medically assisted treatment. The important phrase with medical assistant is the assisted part. There is so much more that needs to be done in terms of wraparound services, social supports, and the like, if we're going to enable individuals to rid themselves of these addictions.
Okay. And that segues very nicely into my next question, which is for you, Jim. Together with Steve, you were among the former governors on President Trump's commission on combating drug addiction and the opioid crisis. One of those recommendations had to do with stigma and combating it. Can you talk to us a little bit about the recommendations and why stigma was something that you focused on?
Let me first clarify that Steve and I weren't on the President's Commission, but we were in a group at the Bipartisan Policy Center that made recommendations to Governor Christie and his colleagues, and we were delighted that he embraced a number of them. I think they had a very good report. I think following up on the comments of my colleagues, this is a key element in our efforts to combat the crisis that we're discussing today. There is a tremendous stigma. Ted referred to some polling information from Harvard. I read some. Am I allowed to mention another institution?
You just did.
Johns Hopkins or Brand X, whatever you call it. But they did some similar surveying and found that the American public has a less positive view of people with opioid dependencies than they do of people with mental health problems. And what was even more troubling, I think, in that study is that providers have the same perceptions. So we've got a lot of work to do to address the stigma, to make it clear that this is a problem we all need to address. We have to have all oars in the water. We have to recognize it as the public health emergency that it is. We appreciate the President's declaration and hope that there'll be some follow-up. A couple of other specific thoughts, Scott. More than half of the pregnant women who are opioid dependent are on Medicaid. So our federal partners, I think, in that program need to be more involved, more aggressive in providing support to them. The current governor of Vermont, Phil Scott, has said that every day a child is born in our little state to an opioid-addicted mom. And obviously across the country it's even more substantial. So that has to be a priority. And a third thought is that in Scott County, Indiana, a few years ago, there was an HIV and hepatitis C outbreak that stemmed from dirty needles and people with opioid dependencies. And Governor Mike Pence issued an executive order to provide syringe services to that county. And after that, HHS mentioned that there are hundreds of counties across the country that have that similar profile and likelihood of an outbreak. So we have to get over that part of the stigma too, to make services available so that people can get on the road to recovery, which is what we all want as a country.
Okay. Jack, as governor of Delaware, you signed into law a bill that cracked down on patients' abilities to abuse drugs by doctor shopping, getting multiple prescriptions, and some other regulations that have led to fewer prescriptions being written for opioids. That, I understand, didn't play out quite as initially anticipated. Could you talk a little bit about the experience?
Yeah, I mean, it's really the law of unintended consequences. And you think you're making progress over here and you're reducing prescription drug abuse, and then people go to other alternatives like heroin. And so, it's whack-a-mole on steroids. And so I think, our current governor, Governor Carney, continues to focus on sort of both sides of it, which I think is really important. And just the whole story of how this has become a crisis, I mean, I think was really well documented in the book Dreamland, talking both about the addictive characteristics of the opioids themselves, paired at the same time with, frankly, a pretty incredible business model for villages in Mexico, which have come up and sort of really gone into some of our smaller towns and focused on the heroin trade. So I mean, this is a massive, massive problem. I'm hopeful and I'm optimistic, and including on the stigma issue that just came up, because I've seen in our state, and my guess is elsewhere, the people who have been the most effective at dealing with the stigma issue are the family members of those who have lost loved ones. In Delaware, there's a group called Attack Addiction. And I don't know, frankly, how they find the personal strength to turn their personal tragedy into something that's better for everybody else. I think if it were my child, I'd probably still be curled up in a fetal position. But there is a group of families who have been, really taken this on. They've developed a very powerful coalition, and they have really been the ones behind so much of the good policy that has come out in our state, and we're all learning from each other.
Great. Okay. Well, the opioid problem has many effects, including on local economies. Let's take a moment to look at this Reuters clip that talks about how the epidemic can hit businesses and smaller towns.
In January and February last year, the primary ambulance service in Indiana County received 6 heroin-related calls. In the first 2 months of this year, it responded to 61.
Over a period of time from June to December of 2016, our organization experienced well over $100,000 in operational losses due to the response to opioids.
Businesses too are struggling. They're finding it hard to find drug-free employees.
You're trying to grow your business, you have opportunities, and we tried to hire last year 50 people to fill a myriad of positions. We narrowed it down to 120. Out of that 120, 40 people either did not pass the drug test or they had a criminal background.
And the opioid crisis, despite national attention, shows no signs of abating. And the costs just keep on climbing.
Jim, you've talked a bit about the need to have a healthy young population to boost economic opportunity. What have you seen in Vermont that can help with this?
Well, there's another crisis out there, frankly, might be the topic of another forum, and that's the demographic crisis, especially in the northeastern United States. We're aging rapidly. In Vermont, we have net out-migration now, more people moving to other states than moving in. Our workforce is shrinking. Number of high school graduates is declining by 1 to 1.5% every year. Last year, we had the lowest number of births since records have been kept in our state. So we've got a real critical economic challenge. And I often said to Vermonters, we've got to have everybody healthy and able to show up to work, or the state's trajectory is going to be very, very problematic. So that's an important reason, I believe, to get, in addition to all the others, to get people the treatment they need, get them on the road to recovery. And the current governor in Vermont has deployed personnel from the state labor department to go to all the recovery centers and work with people who are in treatment to try to get them back on the road to gainful employment. I've believed for a long time that it has to be a multifaceted approach. We're focusing on treatment today, but I launched a program I called DETER, which is an acronym for Drug Enforcement, Treatment, Education, and Rehabilitation, and we attacked all aspects of the challenge, and I think we have to continue to do so if we're going to succeed.
Kathleen, what are some of the barriers that keep people from getting back into the workforce after they've grappled with addiction?
Well, I think a lot of application forms disqualify you from the outset. Questions about drug use and what has been your past experience. And if that's a stoplight at the front end, that actually is a huge barrier to a lot of folks. We've made, I think, a strategic mistake. My early jobs out of college were in the criminal justice area. And we have lots of people who are recipients of the lock-em-up policies that dealt with drug users in a very punitive fashion for decades. Most prisons have cut programs to the bone. That again, resources haven't been there. So we have streams of people who are coming out of institutions who have never had treatment options and could be productive members of society, but absent some kind of treatment initiative, I think they stand to look at failure. And I think the stigma is heavily over the existing work population. Some people who are working are terrified of seeking treatment because they feel they could be fired or they could be disqualified. I am terribly alarmed by what was announced yesterday. We don't even know what the ramifications will be, but the president's announcement that all of the agencies, housing, agriculture, which deals with food stamps, HHS, which has Medicaid as part of it, need to look at ways that they can tighten up requirements, can essentially restrict folks from becoming part of those programs, particularly people who are not job ready. Will you talk about somebody who is struggling with some addiction? Food may be an essential part of that struggle. Housing, supportive housing may. So if we begin to disqualify addicts from accessing the basic wraparound services that have already been referenced, in addition to making it difficult, I mean, we're in for a long-term total disaster. I would say, Scott, one of the most terrifying things I learned as secretary, and this used to come from the military leaders, 40% of our age-ready young Americans could not pass a qualification to be in the armed services right now, 40%. And you think about a national security crisis, that's a huge crisis for this country to be in. So not only is it not a productive workforce, but we are left very vulnerable if among our population, we couldn't have a draft tomorrow if we were attacked, because we have almost half of that age-appropriate population who was incapable because of various health reasons, and addiction is one of them, of qualifying or passing an exam. Pretty terrifying.
One of the key steps in fighting addiction at the individual level is treatment programs. Steve, why don't you talk a little bit about the role that private sector partnerships can play in building this out?
We had I don't know if it's a unique situation in Kentucky, but certainly an interesting one. When I ran for governor in 2007, I defeated an incumbent. And when we came in, I found that he had partnered with a couple of folks in the private sector who were very interested in the addiction problem. And they had started building residential treatment centers with private funds. And that was a darn good thing. And my wife and I both,
you
Jane
didn't
and I,
say it during the campaign, I'm
no,
sure.
but after it was over, and so we picked it up and went to those business folks and kept it going, and we now have 17 of them in the state, and they're residential treatment centers. They, folks can stay a year or whatever they have to in order to they get those wraparound services that Ted was talking about. This whole crisis is also an opportunity in one way. In Kentucky, while I was governor, and I'm a Democrat, I had a Republican Senate and a Democratic House. And it was the issue that finally allowed me to break through that hyper-partisanship that not only infects Kentucky, but infects this whole country, to the point that it is destroying this whole country, in my opinion. And it allowed me to bring Republicans and Democrats together at the table and actually talk and get something done. And obviously, if there's an issue that's not partisan, it's this one. I mean, Republicans, Democrats, and Independents are all dying out here. It's no respecter of political party or anything else. And it's no respecter of economic level. I mean, you have the richest families affected as well as the poorest families affected. So this is an opportunity, in addition to solving a huge crisis, of solving another big crisis in our country, and that's this partisanship crisis that is holding us back from really moving this country forward in 100 different ways.
Okay. Health insurers and drug distributors say that they're taking a lot of steps to rein in overprescription of opioids. What collectively, anyone really is free to jump in on this one. What's your view of how well they're doing, and are they doing enough on these fronts?
I think there's so much more to be done. I mean, one piece is on the doctors, and I know the doctors, push back very, very hard on this. They don't want anybody getting into the patient-doctor relationship. I understand that. I respect that. But when you see people who, may have had a tooth removed being given 30 Percocet, even when the parents request that they be given, one pill of something much less powerful, it's a problem. And I think there's still tremendous education and advocacy to be done there. On the insurance side, our Attorney General, Matt Denn, very creative guy, has launched a program. We got a bill through the legislature where the Department of Justice is actually now taking on patients, representing patients who are having problems getting insurance, getting treatment. And I'm not sure that exists elsewhere, but the government itself is literally representing these individuals to make sure, whether it's a private provider or Medicaid, representing them. And as he said, that tends to, when these folks realize that a lawyer has gotten involved, it tends to clear up a lot of the bottleneck. And so I think, it's a pretty dramatic step, but I think these are the kinds of things that are necessary. And finally, I think so much of the treatment, unfortunately, is very shallow treatment. And one of the most depressing places you can go is to a clinic where everybody's standing in line for their methadone, without getting many of the wraparound services that were described earlier. If we don't get to the root of these issues and give people a chance to clean themselves up, we're trading one kind of addiction for another.
I think it's getting better, Scott. I read a report from Blue Cross Blue Shield in our state that the number of opioid prescriptions has declined 20% over the last 6 months. I think prescribers across the country are beginning to understand that they have a key role to play in addressing this crisis. You mentioned teeth, Jack, and I was also pleased to see a recent report that the American Dental Association has passed a resolution encouraging its members to be better educated, to limit their dosages of prescriptions and get more involved as well. So I think the tide is turning a little. Steve and I both had our spouses' recent experiences with injuries that resulted in substantial overprescribing of opioids, and so I hope we're on the right track.
Ted, how are we doing as a nation in terms of combating pill mills and that problem, which kind of feeds this issue?
Well, we're doing much better. But as I have emphasized in the past, this problem really began, I think, in part because of the irresponsible use of these medications by irresponsible profit-seeking physicians. And some of them have gone to jail, thankfully. And in my in my region of Ohio, it was a particular problem where physicians would set up these pill mills and sell prescriptions basically for $75 cash without accepting insurance or credit cards or anything, only cash. And when I called the Ohio Medical Association, their first response to me was, we cannot tell our physicians how to practice medicine. But the fact is that's changed. Things are much better in that regard. But I continue to believe that, as I think Jack made reference to root causes, this scourge is affecting every segment of society from the richest to the poorest. And I think we need to put some resources into research to try to identify some of the root causes, and whether or not just providing appropriate treatment is going to solve the problem. I think has been mentioned here several times, providing comprehensive or wraparound services to people. There is no silver bullet to dealing with these addiction problems, but we've got to make sure that everybody, including the pharmaceutical companies the medical community, political leaders, and law enforcement are all working together to try to find the appropriate solutions.
Scott, I would say that the House and Senate bills that are currently pending both have additional directives to NIH to do more research. One of the missing pieces, the shift to pain treatment in the 90s, I think it was very positive for a lot of patients, but had some unintended consequences. What's pretty clear is that there's not enough substantial research on what is the long-term impact. We know there's a short-term impact on pain management, post-surgery, post-trauma, but very little or sketchy long-term impact. So that's one big piece of the puzzle. But I think, again, it begs the sort of federal-state partnerships. The states have to be the front line of the treatment centers and the funding for the gaps that exist and identifying people and working with employers. I think the federal government has research, and the appropriate, to me, law enforcement is really, again, cracking down on whether it's heroin or fentanyl, which basically come in from other countries. So even if we stop opioid overprescription, if we have success on that level, if people can just flip to a cheaper but frankly more sustainable high, we've done whack-a-mole all over again. So I think it begs for, you can't do one thing. We have to do all these things, and we got to do them for a period of time, or we will never work our way out of what has been 20 years building.
Yeah, long sustained effort is the only answer. It's just like you said, if we don't get in this and stay in this, and if we don't get a plan together that everybody buys into. I mean, this legislation, the budget stuff that just passed, $3 or $4 billion in there, and it's all good ideas, and but we're basically scattergunning. Just a shotgun approach. Well, let's try this and try this for a year or two. And, we need leadership that steps up and says nationally, this is a crisis, it's an epidemic, we're going to take it on and we're going to solve it. And the states need to get on as partners, and all of us are going to be in this together. And we got to kind of reorient our doctors and hospitals and everybody, just like we did with the AIDS epidemic, to really deal with this and get a handle on it and get some control out of it. And, until we do that, we're just going to keep, we're doing good stuff, but it's not going to be good enough.
How broad is the gap between the funds that states need to combat this issue and what they're getting from the feds, and how would you address that given the opportunity to do so?
Well, it's a huge gap. And look, when you talk about treatment, and we've all talked about this, these 30-day programs, I think for most people you might as well not have them because this has got to be a sustained.
But the lucky people these days are the ones who get 30 days.
Oh, yeah.
Yeah.
Yeah. But these residential treatment centers are probably one of the main things we're going to have to do, and that's expensive. That's really expensive, and none of us in our states ever had the kind of money it takes to do that. Now, because of my hero over here that got the ACA into effect and helped me do it in Kentucky, Kathleen, those 10 essential benefits included, as she mentioned, treatment for addiction and for mental health. And my gosh, that's been a lifeline for us. But even then, it's not enough.
But I think we also don't have the workforce. Yeah. We talked about stigma earlier, Jim did, and I think, Jack, you referred to it. I've done some work on this issue with the Aspen Health Strategy Group, a bipartisan effort, again, with former governors. Tommy Thompson is my partner on this. And one of the research issues was done among healthcare providers. And healthcare providers regard treatment of addiction and those individuals who are skilled in treatment of addiction as sort of a lower level of healthcare. It has its own stigma within the healthcare profession. Fewer doctors want to do it. Fewer nurse practitioners want to do it. It's not regarded as either esteemed or well paid. So we have a problem with, if you have treatment beds, if you can put that physical infrastructure together, who's going to work there? And how many people, if we adequately are going to deal with folks in all kinds of settings, who is it that's going to be in that pipeline to come forward and say, all right, we're going to step up and do this work? Because I think the stigma for patients is equally apparent in the provider community, which is pretty terrifying.
And certainly the stigma goes far beyond that. That's obviously a critical piece of it. Jack, why don't you talk a little bit about some other ways that the stigma affects both addicts and their families?
Well, I think, actually, if I could pick up on what Kathleen just talked about, the irony is this is actually where we need our very best people, because the complexity of dealing with these issues, the detox alone, it can be, a week, 2 weeks, just the medical management of that, then dealing with all the family issues, people who may be in denial, the need to do interventions, just, finding skilled people who can work with families and support. It is a crisis for not only for the country, it's a crisis for each of these families, because it can have so many impacts on health care, continuing in a job, schooling, inter-family dynamics and the like. And so, not only do we need to focus on having the, reducing the stigma for the workforce, we actually need the very best people, because the complexity of dealing with these issues is as high as for just about anything.
On the financial point that you raised, Scott, the first resources we got for our very first recovery center in Vermont was a congressional earmark, courtesy of one of our senators. The term isn't in favor everywhere, but it jump-started our efforts at getting that first recovery center going. And so there's going to have to be some federal participation. And what really concerns me is that we're now in the, 8th year of a recovery. These are the good times. And we all know what's going to happen. In the not-too-distant future, there'll be a downturn when state budgets are going to tighten up again, and we won't have the resources to commit to this and other important programs. So this is the time, I think, that we need to make that commitment, and I hope everybody will.
Okay.
One of the things I just wanted to add, particularly for our younger people, there's a move in Delaware, a number of states, toward recovery high schools. And you think about the challenges that so many of our young people have, and many of them do have it. And so this idea of setting up schools sort of specifically designed for them with the supports that are necessary. And again, this is an issue that organization I mentioned, Attack Addiction, is really leading the way on. And there's nobody better positioned, because so many of them have lost their young ones to the scourge.
Right. And I'm glad
speaking of young ones, you also have this generation of babies being born in NICUs. At least half of the births in the United States are paid for by Medicaid, and I gather, it may be higher, but what is it that those, total innocents are going to need to survive and thrive? What are the health issues? What are the mental health issues? What are the services? Because this is now a multi-generational, not just an impact on the addict, but what happens with those children?
Because it's several. I've seen reports that it's up to 3 or 4%.
It's terrifying.
Of babies who are born addicted.
Yeah. We're obviously focusing on this rightly as a crisis. There are some steps out there that are starting to work a little bit. And I'd like to hear from each of you. I'm going to start with you, Ted, so we don't neglect you, with something that's working in your state that you think's effective. So, Ted, why don't you take it away from Ohio?
Well, I'll tell you what I hope is a success story. I'm not certain, but last December I was driving down the highway going to Athens, Ohio to teach a class, and I see a guy hitchhiking alongside the highway. I stop, pick him up. It's a cold, bitterly cold morning. He gets in my car and he says, "Thanks for stopping." I said, "Tell me about yourself." He said, "Well, I just got out of prison. I'm on my way to drug treatment. I really want to kick this addiction," he said. "And if you miss 3 sessions, they kick you out of the program." He said, "I haven't missed any yet. I'm going to be late this morning, but I don't think they'll care if I just show up." I've thought about that man a lot. No car, no job, prison record, and addiction, walking to drug treatment on a very cold morning. And that gives me hope that there are people like that who will accept treatment, want treatment, and we've got a responsibility to make sure that treatment is available to them. I hope that man, I may never see him again, but I hope that he's a success story, because I know he's trying.
Great.
Well, I think drug courts have been successful in many cases. I sat in for about half a day in drug court in Vermont a few years ago, and it was quite compelling to see people at different stages of recovery coming before the judge, who was offering a carrot and stick approach. Perhaps some others have seen this, where if someone is following his or her agreed upon progress protocol, then the judge might say, here's a ticket to a movie, maybe take a friend or a couple of tickets, and if not, I saw the judge order the defendant to write yet another essay about the problem and to bring it back in to read at a later time. So I think in many cases those are helpful. But I have a story very similar to Ted's. There's it wasn't personal, but relayed to me. There's a fellow named Charlie in northwestern Vermont who was a college freshman hockey player who suffered a knee injury and was prescribed some painkillers. And as he related the story publicly, he said, I knew that I was a tough athlete. I wasn't going to get hooked on anything. Well, you know what happened. He did. He got into heroin. Then he passed bad checks to get money for drugs. He went to jail, and things were looking pretty bleak. He was fortunately taken into a medication-assisted treatment program in our state, and it was quite successful. And now Charlie is 24. He has a job. He has a condo. He has a girlfriend. He's got lots of other friends. He has 2 dogs, and I hope that there'll be a lot more folks like the young man to whom Ted referred, and Charlie from Vermont, who can make it and get onto the road, get on the road to better life.
To pick up on the drug court issue, as governor of Kansas, we were able to pass a law in the early 2000s, mid-2000s, I guess, that dealt with, we wanted to make it retroactive. The Republican legislature only wanted it prospective, but that was good enough. If you were a nonviolent drug user, you got an alternative sentence that stood in front of your prison sentence. And if you were successful in the program, which included work training, rehab, your prison sentence disappeared. If not, you ended up in prison. One was about $25,000 a year for the prison. One was closer to $2,500 a year for the in-place treatment. And we actually were able to empty a lot of beds that would have been used. We were on track to build a new prison that never got built. But if that can happen in a state like Kansas, a pretty red conservative state, it made sense to people as a financial alternative, as a bargain. And I think those kinds of things are able to be put in play. And it's one piece. Again, we need to do 15 things simultaneously at the federal and state level. And pulling one trigger or another probably isn't going to solve this, but trying to take advantage of the president's declaration that this is a national public health crisis and then treat it as such with resources and revenue and multiple solutions, I think could offer some possibilities for brighter futures for these guys.
And one of the things that encourages me is that I think all of us and policymakers and elected officials across the country have been so humbled by the difficulty of dealing with this crisis, is that more and more policymakers are going to the people themselves for ideas. Because we don't have, with due respect to my colleagues, we don't have, we will learn so much when we go out and ask. And I know in Delaware, our Lieutenant Governor, Bethany Hall-Long, she's actually a nurse, has convened a series of town hall meetings. And although the stigma issue is real, it has been remarkable in our state for the last couple of years. Anytime there's any kind of town hall or public forum, it's standing room only. because people are desperate. And they're looking to network with others. They're looking to advocate with their policymakers. And I think some of the information that she's leading up a behavioral health consortium. I mean, it's really, this is not about pie in the sky 30,000-foot policy. This is about meeting people where they are. Right. And it's about more community health workers. It's about more detox beds. We have a commission that reviews every overdose death to really understand what's going on. And I think, you know, we really do need to be very humble, and as policymakers, we need to be willing to ask for advice from the people who are most directly impacted.
You know, in Kentucky, Scott, we, like Jack and others, were pretty successful in going after the pills. You know, we kind of figured out a number of things that worked in terms of, not in the treatment area still, we didn't have enough money there really, but you know, requiring all the prescribers to use the monitoring systems and running the pill mills out of the state, those kinds of things. And then of course, you could tell we were successful because heroin and fentanyl popped up. You know, boom, just like you said, guacamole on steroids. And, but in Kentucky, and I was honestly surprised, a little more than surprised, that we were able to pass needle exchange legislation that allows that in Kentucky. It's a local option, but it is allowed in Kentucky. When I proposed the legislation, I thought, boy, this is one thing that we're not going to get done. But we got it done. And of course, naloxone, getting that out there is an easier call, and we got that out on the streets. And then we passed a Good Samaritan law, which allows somebody that's sitting there with the person that overdoses and they're both using, you know, they can call 911 and not get arrested and go to jail because they called, and so you're going to save a life. So we've done some interestingly progressive things in another red conservative state, just like Kansas, but still.
It's all those K states.
Yeah, that's right. That's right. Just states that start with K. That's exactly right.
I wonder, you talk about needle exchange, and I go back to, you know, you're talking about consistent messaging, federal messaging. That seems to be an illustration of the effectiveness of the federal messaging on AIDS, right? Because that's what it's about. This was people to get beyond, you know, okay, this is something I'm uncomfortable with, to, well, this is a bigger problem that we have to do something about.
Right, and one thing that helped us, and Jim actually mentioned it, is that right when I was trying to pass this in Kentucky, this case in Scott County, Indiana popped up, and Mike Pence, of all people, who was governor at that time, ended up having to put needle exchanges in. And so I said, look, if Governor Pence can do it, we can do it. But obviously that's one that really carries a stigma, and I understand it. But an additional benefit of it, in addition to just saving lives, is it puts the professionals in contact with the user. Right. You know, and you hopefully are able to begin having a conversation with that person who comes in to get a new needle of, look, we've got these programs. I mean, you know, let us work with you. Let us try to help. And so it helps you identify these people, and you actually end up being able to pull some of them into a treatment program.
So I have a challenge, as President Obama always liked to say. You know, you need a do-out from a meeting. You need what the next step is. And I'm delighted to be here at the Harvard School of Public Health, because I think there's a unique role that public health institutions can play, and this is the best of the best. So having some kind of a very interactive database where any policymaker can go on and what works, what has been the experience, how much does it cost, in very practical terms. Lots of good ideas that have worked in various states. Nobody should have to reinvent the wheel, but I'm not sure that kind of really good database exists. And you know, hopefully the feds could add to it, but even just governors and local policymakers exchanging what are the 10 things you could do tomorrow if you're really serious about that, how much it costs, who are the experts in Delaware and in Vermont and in Kentucky to call. I don't see the federal government filling that gap right now. Data is disappearing, not being populated. So I think it's a great role for a public health excellent institution to just capture data and put it in a way that's very user-friendly, very able to be accessed. And so people who want to do something,
Right.
and they only have X amount of dollars, what are the 3 best things they could do? Where are the gaps in Kansas or Vermont, and how to put that together? I think that would be a wonderful way to at least keep the momentum going and capture people's really good ideas.
Interesting recommendation, and it actually brings me to what I was hoping to conclude this with. I was going to ask each of the rest of you to offer one policy recommendation or takeaway that people who are watching this online, whether they be policymakers or academics, whatnot, can take away. And Ted, once again, I'm going to go to you first, just so we don't neglect you. What's your advice?
Well, that these treatment programs that are being developed be closely monitored for effectiveness, and that we rely only on evidence-based treatment approaches. I think we're always in danger of people looking for quick fixes, and this is a long-term problem that's going to take comprehensive services in order to provide effective outcomes. And so I would just say, let's monitor our efforts to make sure that they are credible and defensible and are science-based.
We need to start a movement across this country that culminates in a national plan to attack this. And that's not going to be easy. But if we get our public institutions involved and all the professionals involved, because everybody really knows this. We know that that's what we've got to do, but it doesn't really have a focus right now, and we need to somehow focus an effort to convince this administration and Congress that it's all well and good, the pieces that you all are doing, but we need to treat this for what it is. I mean, this is a thing that can destroy this country if we don't get good control of it. And we've got a lot of examples that we've done this in the past with HIV, AIDS, and others, and we can do this if we just pull together and get it done.
Jim?
I agree with that, of course, but as governors, we always wanted state flexibility. One size doesn't fit all, and so I think it has to have that component. I think of the waivers that Secretary Sebelius graciously granted to Vermont to make us the healthiest state in America for a number of years running. And we've got some faith-based recovery programs in our state that seem to be working quite well. So with a local flavor. And I guess the comprehensiveness of this challenge keeps coming back into my mind. Jack mentioned the community health workers and the patient-centered medical home where somebody can get access to all the kinds of professionals that are necessary and perhaps be an early indicator that there's an issue that needs to be addressed. So a targeted approach, a national message, but one that works within the context of each individual state.
And since we're having this conversation at the Harvard School of Public Health, I'll address your questions really speaking to the students, which is the researchers and the academics and the advocates need each other. We do need a real plan. It's got to be an evidence-based plan. But you've also got to team up with those who understand how to advocate and how to build a coalition, because we really need both.
Yep.
Great. Well, I want to thank all you governors for being here today. I want to thank everybody in the room for being so attentive, and our many viewers online. And I'd like to invite you to come back next week for another Harvard School of Public Health Forum on college students and mental health, confronting an emerging crisis. That's on April 17th. Thanks for joining us.